Welcome to Talking HealthTech. My name is Peter Birch. Today I'm in Brisbane at GP25, which is the annual conference for the Royal Australian College of General Practitioners. This is the largest national gathering dedicated to general practice, where the doctors of Australia come together for learning and professional growth, as well as plenty of other opportunities to connect with peers, industry leaders, and healthcare professionals across the country. During the event, I got to catch up with a number of speakers that were presenting here at the event to bring you this special feature episode of the podcast today. We cover topics like the entrance of private health insurers into primary care, bulk billing changes and what that means for GPs and patients, as well as healthcare's impact on climate, and of course artificial intelligence, plus a lot more too. Collaboration starts with a conversation, Team HealthTech. Let's make it happen.
So my name's Max Mollenkopf. I'm a GP and practice owner in Newcastle in New South Wales, and I'm here at the conference because I think it's just an interesting mix of things. I think the college conferences have always got a lot going on, and it's a nice mix of old friends and new friends.
It's great to chat in person, man. I don't think we've not done that. A lot of chat online, but good to spend some time face to face. So you're not just out on the floor and connecting with other GPs, but you're also up on stages too. Tell me what you're sharing.
Yes, I've got a panel this afternoon. It's a panel on the role of private health insurers in primary care, which I think is it's a really interesting space. There's obviously been a lot of movement in this space and a lot of acquisitions, and I think that ultimately general practitioners are a little bit confused at the moment about what's going on. So we get told that private health insurers can't do a lot of things in our space. We get told by practice owners and we get told by small independent business that maybe our practices aren't particularly viable. But then at the same time, we have huge private health insurance groups coming in and saying, well, actually, I'm going to collect 100 of your clinics.
Yes.
And for us as clinicians on the ground, we're sort of saying, what does this mean for us? What is going on? What is the end game? What are you guys hoping to achieve in this space? And the side note is always, are we going to go down a path of the United States where perhaps we have a lot of conflict with insurers about what they'll pay for and what they don't? We spend a lot more time, a lot more red tape, a lot more admin. But then on the flip side, is there some opportunity here for new funding in the space? We already have patients who are sitting in front of us who are paying for their private health insurance. They are struggling with cost of living pressures. We're making health recommendations to them that they may or may not be able to actually afford to go and do.
Yeah.
So bringing new funding into the space is going to be welcome. But yeah, there's a lot of tension here about what's going on and what's going to happen next.
Yeah. Is that tension, because you being a independent clinic owner in Newcastle, and people can go back into the feed recently, you had a longer episode as well, but is the tension more on that commercial business model? Like, you've got to keep your clinic running, and then, is that competitive to having, say, big insurance coming in and doing that? Or is it more concerns around the continuity of care for patients, and the clinical side, or is it a bit of everything?
I think, like most things, it's a bit of both. So if we look at it the three levels, at the patient level, there is concerns from clinicians about patients, let's just say the impetus for the patient, what we're trying to achieve for them. Is that for the best interests of the patients or the best interests of the insurer and their bottom line?
Yes.
If we look at the clinician level, am I being incentivized to act in a certain way that's in the benefit for my patient? Am I being incentivized to act in the benefit of the insurer? Do those things actually align and we're heading in the same direction? And is my remuneration going to suffer because of a sort of an insurer's payment model? And then when we look at the independent clinic level, I think it's a very interesting player in the space where they have a lot more money and a lot more power, and they have a lot of sort of vertically integrated services. They have a lot more going on. So if I look at it as an independent clinic, I don't necessarily have that same firepower to compete. And so it certainly brings more competition into the landscape. And, ultimately that may benefit patients and harm me, but we're not really sure what's going to play out. There are existing models in market. We do have insurers that are owning GP practice groups, and it seems to be a little bit quiet on that front. They see some kind of transitions into health programs, weight management programs, things like that. They haven't really flexed a lot of muscle in the space, but yeah, it's a lot of us are looking at, say, Bupa and now the Better Medical acquisition and saying, well, what else is going to go on here over the next 12 months?
Interesting. Well, that'll be a good panel. Is there anything else that you think will be a pretty consistent theme amongst GPs here at GP25 over the weekend?
I think the other thing that we're hearing a lot about is obviously the bulk billing changes and having the minister in yesterday and reiterating the fact that he feels his obligation is to the voters, and especially to low and middle income voters who are struggling with cost of living. There was a lot of chat about the fact that while reform is important, bulk billing is their metric that they find to be the most important thing, and that's not going to go not going to go away anytime soon. So for clinicians on the ground, there's a real spot here where for a large group of GPs, this is actually very beneficial. The minister is right. You can't play down the fact that he's injecting new funds into the area, and if you are a bulk billing general practitioner or bulk billing clinic, you are going to receive more money that you weren't getting 1 month ago. If you are a mixed or private billing practice, it will change your market landscape, where now there are much more heavily advertised and funded bulk billing practices around, and it might shift you if you're on the fence. If you're a private billing practice, you need to relook at your offering to say, okay, well, if the government is going to continue to push people harder and harder into bulk billing clinics, what are you going to do differently moving forward? So it's kind of a shifting market. Underneath all that is also the fact the minister has spoken about in Canberra, and he's name-checked Newcastle as well, as these areas that he references as bulk billing deserts, and the fact the government is going to come in and they are going to manipulate the market locally. For me, as a clinician and clinic owner in Newcastle, that's something that will put pressure on us locally about how we behave. So yeah, it's just a landscape that's dynamic and shifting, and there's a lot of players who are coming in and trying to push it in one direction or the other. It's never been a free market, but it's even less of one now than it was before.
I'm Michael Bonning. I'm a GP in Sydney. I'm at GP25, but the things people kind of know me for is I was a former state AMA president, and I've been pretty heavily involved in the college, mainly in funding and health system reform. Yeah.
Great to have you here, Michael. Good catching up, and you're a popular guy at these things. It's difficult to even get the interview started.
I am 6.5 feet tall, which means I'm very visible at conference. I think is more than anything else. People will do that to me. So.
You're underselling yourself. But so what brings you to GP25 this year?
As always, the other problem that you just talked about, it's nice to catch up with people. Like I really find it's a good sessions, but also all the social event is really fun. But today I'm chairing and running the session on private health insurance in primary care. So a really important topic, which I don't think we cover enough, given that there has been significant moves by private health insurance to take ownership stakes in general practice, but also change the model of general practice, provide telehealth services to their members, which would traditionally be the environment of their regular GP. So lots of things that are just changing the relationship where previously insurers just did insurance and were quite a long way outside the space of primary care.
What's good in this episode of Talking HealthTech, caught up with Max earlier, who people would have just heard that conversation, now chatting with you.
My job is to keep Max in line.
I was going to say, you're chairing the conversation, so I guess you get some level of independence or steering the ship, but there's going to be some interesting perspectives. What are you expecting from the session?
What I think we would like to see is an understanding for everyone in the audience, if you're a contractor GP, if you're a practice owner, if you're a large group, proprietor, about what private health insurance is trying to do in general practice. Like, what is their motivation? Because there's this big kind of elephant in the room, which is private health insurance is hoovering up general practices. But on the flip side, the narrative is that general practice is really financially struggling. So if you're a sophisticated, large organisation, what is your game in terms of general practices, and how do you kind of execute on that? And then what does it mean for us who go to work and look after our patients? Does it make a difference then if suddenly one of my patients is a Bupa member, a Medibank member, an HCF member, an NIB member? And what does that mean? And then also, what does it mean for all the patients who aren't? Because that's half the population too. And many of those are also the ones who have more complex chronic disease because they're often less socioeconomically advantaged.
You mentioned, it's not a topic that we've talked about too often in terms of private health insurance and GPs, and that whole point around, the business model of general practice. It's interesting that there's, large corporate private health getting involved. There's obviously work done there, so that'd be an interesting take. General practice isn't new, though, however, to the concept of disruptive models of care around your traditional bricks and mortar clinics, and we've talked about pharmacy's role and telehealth and all of these elements. So that concept of it's not too new. I mean, on one hand, I would think, geez, it's a bit of a tough gig being a GP, but what's your take on it?
Well, it is, and the real challenge is how do we stake out the ground that is where a GP is really valuable? Because lots of times we're saying to others, no, don't do that, that's ours, as opposed to being really positive about what is general practice's role and then going and owning that. Because I will say this of the Pharmacy Guild and others, they are very clear on what they're trying to position themselves as. The nurses and nurse practitioners, very clear on what they're trying to position themselves as. And then in this kind of broader discussion that we're having, if private health insurance, we think of them as another big player in the space. Well, what leverage do they have over GPs? How are they seeking to change our role? Because I know that the independence and autonomy that I get through making decisions that are only driven by, the interrelationship between the patient and myself and good guidelines and good practice is critical to doing my job well.
Interesting. What other topics do you think are kind of front of mind to delegates and GPs that are attending here at the event?
There's a lot on leadership, and because that feeds into the last part, which was how do we define ourselves as a specialty, as a community of practice? What are we doing about where our future goes? In addition to that, the likelihood of, what does AI do in our space and how does it both disrupt but really augment? Because if you are a, proceduralist, non-GP specialist, it's a longer runway to the disruption of AI in your specialty. But for me, who is a generalist and who has to think about hundreds of conditions in at any one time, but also the behavioural overlay, the socio-economic overlay, people's past experience and lived life experience, and put all that. There are plenty of things that AI can't do, but they can certainly help me. We were just talking, the Red Book, great, life course, understanding. But what I really need is also the dynamism of that into some kind of agent that can help me say, what should I be screening for? What should I be case finding for? What should I be opportunistic about? And that's, as medicine gets more complicated, that's actually a huge asset to us.
Yeah, that's something I've thought about from time to time with, the advent, the benefits of artificial intelligence, what the technology can do well and what the humans can do well. And I guess historically, one might take the view of a general practitioner who might be, seen as the jack of all trades or the place that the catch-all, so needs that, breadth of knowledge of, something about everything. Surely that's not the biggest strength of a human brain. Like the capability of a GP is massive generally, but it's that cognitive load or that just retention of knowledge. It almost seems a little bit, unfathomable to be sustainable, but that's what AI can do really well. So it'd be interesting where that kind of crosses over and benefits.
Well, and keeps the human component of practice as well. I think of something I did on Wednesday, Thursday this week in practice. Patient of mine sees me very regularly, very complex, and we were thinking about options. She's had very low mood, she feels no joy anymore, she's been on lots of different medications across her life, and thinking about not just my knowledge, which is of her last many years, but her knowledge of her own life, and how do we make sure that's also being surfaced when we talk about it. Because otherwise AI would give me, here's a whole heap of clinical things like therapeutic guidelines. It would give me a whole heap of things that these are the things to do. But the things that get knocked out are like, oh, I was on that before, that was terrible. I was on that before, that gave me huge weight gain. I was on that before, it made me not be able to sleep. All of those things are really important to, how do you keep the patient engaged in the consultation? And this is part of what we did. We sat there with options and really thought about, well, here are the pros and cons. How do we want to weigh them for you? How do you want to weigh what should be our next step as a patient? And that's the part that I think that is intrinsically human because I know her really well.
Lastly, as GPs make their way back to reality after spending the weekend in Brisbane, Vegas, what would you hope that delegates take away from the event?
Coming to conference is always the art of the possible. All of these things that we could do and can do, and a couple of my practice colleagues are here as well. And I think if we could take away a really good understanding of what we might see as change in our sector and how we kind of get on board with that, because AI as one is really it's coming. And I think we as GPs need to have real ownership of that. That's one area. I think secondly, as always, this is our annual scientific meeting. We should be getting better at what we do. I just came from a session on the Red Book, preventative activities in general practice. That's where we really excel. We know people across their lives, therefore we should be doing as much preventative work with them as we can. And people outside of general practice are hijacking that. It's called longevity medicine now, but we've been doing longevity medicine forever, but we've got to work out how to make that sexy again in primary care, because I know that I change people's trajectories in their healthcare all the time, but I've also got someone who's charging them thousands of dollars to do that. And that is a real distinction that we need to get back on board with and make the case that general practice is so fundamental to people's long, healthy, active lives.
All right, so my name's Nicole. I'm a GP up in Gimoi, which is Cairns in Far North Queensland, and I'm at the RACGP GP25 conference. I'm the incoming chair of the RACGP Climate and Environmental Medicine Specific Interest Group. And then generally part-time GP in clinical practice and part-time strong advocate for action on climate change for the sake of health and raising awareness about the relationship between the health of our planetary ecosystems and human health.
Love it. The environmental and planetary impact of healthcare. For those that are across that, they'd be like, yeah, of course. Others may be like, what exactly are we talking about here? Tell me about what that impact is.
Yeah, so healthcare has a massive carbon and environmental footprint on a global scale. If healthcare were a country, then we would be the 5th largest emitter globally, which is huge. Wow. And in Australia, the Australian healthcare sector emits approximately 7% of the country's total greenhouse gas emissions, which is quite large, as you can imagine.
How does that, like, what is the output of, like, healthcare that causes such a dramatic effect?
Yeah. So running of hospitals that's like a huge hotspot essentially, which is just the infrastructure required and the energy required to run that. Transport, pharmaceuticals has a massive carbon footprint, which starts from where they're produced and the whole production process, the transport to come reach Australia. So in general practice, for example, they're our biggest carbon hotspot is pharmaceuticals. Transport, pharmaceuticals, waste. Create energy generation, pretty much everything we do in healthcare. Everything, whenever we're producing something on the planet, obviously we're, creating energy, burning carbon. But particularly healthcare, it's a huge sector in itself, and we have a massive environmental impact.
Interesting. And it has such a massive environmental impact, but it's a really important thing that needs to happen. So how do we find this balance?
Yeah, it's difficult because, we're a sector built on first do no harm. I took that pledge when I finished university, and but actually we're doing a lot of harm. And I think the thing that we need to do now is we need to transform the way that we deliver healthcare and the way that we understand the role of healthcare, because you're right, we need to provide healthcare. Definitely, but we're in the midst of a non-communicable disease epidemic. So more than 70% of what we see in the Australian healthcare sector and globally are preventable, sometimes even reversible chronic diseases, and we're treating them in a way of illness pharmaceuticals, hospital admissions. But in actual fact, these are preventable illnesses. And so if we take a step back and transform to a sector that is truly built on health, then it would change what we're doing. Yes.
And so, geez, I feel like sometimes we can't catch a break in healthcare, though. Like it's kind of like, oh, now this is another thing that needs to be addressed. Is it achievable? Like in your mind, are there actionable steps that people can take within healthcare on a day-to-day to have an impact, or is it something that really needs to happen at a whole of ecosystem? Level?
I would say it's both. So when we talk about decarbonising healthcare, there's kind of three main steps.
Yes.
So the first step is investing in health. So it's truly investing in health where we keep people well, we keep people independent and out of hospital. And that really means like proper preventative and primary healthcare.
Yes.
And, that's government policy, and it's supporting GPs like us to do the work where we can keep people out of hospital, support people to be well. The second thing is to minimise low-value care or harmful care. So low-value care is care which after, we provide the care, but in actual fact, when you move further down the line, it doesn't make any difference to the outcome for that patient, or it might be harmful. And interestingly, 40% of the care that we provide in the Australian health system is either low-value or harmful. So 40% it's a huge amount of care which doesn't need to happen or is actually causing bad outcomes. So we need to reduce that, minimise it. And then the third step we need to take is to decarbonise high-value care.
Yes.
High-value care is care which obviously does provide good outcomes, helps our patients, but there are low-carbon alternatives to many of these. So one example, is like respiratory inhalers.
Yep.
Yeah, so the blue inhalers, the asthma puffers, they have very potent greenhouse gases. And anybody who uses the Ventolin really regularly likely has really poor asthma control. And so giving really good asthma control and wherever possible choosing a low-carbon inhaler represents high-value care, and it's also low-carbon care.
Oh, so interesting.
Another option would be, would be like lifestyle interventions before pharmaceuticals.
Yeah.
Yeah, so that's high-value care, when people are exercising or changing their diet rather than starting a diabetes medication.
Yes.
It's better for them, it's better for the planet, has a much lower carbon footprint.
Yeah, fascinating. And you're here at GP25, and I believe you're up on a stage, and
Yes.
I'm going to guess that you're speaking about something in this wheelhouse. Is that right?
Yeah, so tomorrow myself and my two colleagues who are part of the Climate SIG and also Doctors for the Environment Australia, we're speaking on net zero healthcare. Where are we and where are we going?
Amazing. And if there's anything that you would hope the participants who are attending the session take away, just to close out the conversation, what would you hope that people take away from your session?
Probably three things.
Okay.
So the first thing is that climate change is the greatest threat to human health that we're faced in this time.
Yes.
We need to take it seriously.
Yep.
The second thing is that as a sector, we have to do our part, which means that we need to truly decarbonise, and we also need to build a climate resilient health sector because we're bearing the brunt of all the health impacts of climate change, which are huge. And the third thing is that there are absolutely steps that we can all do in our day-to-day practice, and one of these could be simply joining a group like the Climate and Environmental Medicine Specific Interest Group, or Doctors for the Environment Australia, or the Climate and Health Alliance, and then other things could learn by coming along to our talk tomorrow. Yes, but are essentially those three steps where we truly invest in health, and advocacy is a really important thing, advocating for good public health care and investment in primary health care. Number two, minimise low value and harmful care. And number three, decarbonise high value care.
We hope you enjoyed this episode of Talking HealthTech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.